Let's look at a few clinical studies. So this is a paper from Switzerland by Mark Barbero, and they really looked at that. It's like clinically relevant. We saw already some basic research studies from China earlier this morning. In this paper, they said, like, yes, the trigger point phenomenon has very good face validity. It is clinically relevant. That's why we're all here today. And you should consider the contribution of trigger points to pain and disability. But also, they also found that, yes, you do need to include trigger points in a multimodal program that includes dry needling, manual therapy, and I would add to that exercise stuff as I discussed with you before. The internal and external validity of research within the field must be improved, but that has a lot to do with the quality of studies. And I 100% agree with this, but there are many issues with dry needling studies. First of all, there are only very few excellent dry needling studies, which is frustrating. And that's really why we're trying to do this review, to kind of help you understand, like, what's the status, what do we know. Many of the studies, and if you have read some of our review articles, you see that that's probably the most common thing we comment on is a lack of really lots of methodological issues. Very small sample sizes, one needle stick, and with very big conclusions. Yeah, you saw several of these papers already in this session this morning. People got stuck once with the needle compared to some sham intervention or something else, exercise or laser or whatever it may be. And then big conclusions are drawn, like dry needling does or does not work. And that's a problem. That has nothing to do with dry needling. That has something to do with sticking someone once. Lack of control groups is still a big issue. I honestly don't understand, why would you do a big study? That's a lot of work if you don't add a control group. It adds a little bit more work, but it has much more validity. Proper blinding is a big problem. You can't really blind the therapist, like whether you do dry needling or not. You can blind the patient. There's some sham needles on the market that you could use. They all have their issues. None of them are perfect. You can use independent observers who take all the measurements, but double blinding, oh my God, that is really, really hard. So the current evidence is not always robust enough from a strict scientific point of view to draw firm conclusions regarding the efficacy of dry needling, and that's just the way it is. That doesn't mean you have to stop doing it, because we still see our patients getting better, and we still have a lot of research that's very, very positive, that really is well done and looks really good. Felicity Braithwaite in Australia did her doctoral thesis on the whole blinding issue in dry needling. She's published several excellent papers. She did a Delphi study. I actually participated in these Delphi studies and communicated with her several times about it. This was actually done in conjunction with Lorimer Mosley, who is not a big fan of dry needling because of some of these research issues that I just pointed out to you. But she gave some suggestions how to do it better. But from a pragmatic point of view, I'm not really sure how to do it better, to be honest. Like, how do you really blind patients and clinicians to whether you do dry needling or not? So it leads to some confusion. So there is research that shows that dry needling works. There's also research that shows that dry needling does not work. This is a picture in a course in Ireland. So a study last year in the Journal of Orthopedic Sports Physical Therapy from Brazil showed that dry needling does not work. A large study, 616 subjects, that looked at neck muscles, as you can see here. They did elicit twitch responses. There was no blinding. At the same time, actually in exactly the same month, another study was published doing basically exactly the same thing. So I thought it would be kind of fun to contrast these two studies, to present them to you next to each other. The needle size in this study must have been a typo. They had needles with a thickness of 40 millimeters, so that's impossible. That's 4 centimeters. That's an inch and a half. So I think it was probably 0.4, but I don't know what it was supposed to be. I can't really speculate. I did not contact the authors to get that clarified, but this is what it said in the paper. Also looked at some of the upper cervical muscles. Also elicit twitch response, also no blinding. So the first one, after 1 month, looking at pain intensity, was only a very small reduction in average pain intensity. The Spanish study, pain intensity was significantly lower than in the sham group at all points post-intervention. And they actually gave you the numbers. In the Brazilian study, there was no difference whatsoever. But here you see quite a big difference. Significant is this from 4.89 to 2.83, comparing the two groups. The study that says dry needling did not work found no significant changes in the group by time interaction for disability measures in the neck disability index. And 1 month later, there was no difference between the groups at all. The Spanish study, which basically was the same study in many ways, found a significant lower disability ratings, also using the neck disability index, so the same outcome measure even, in the dry needling plus manual therapy group compared to the sham needling plus manual therapy group. And you can see that here. So continuing with the study that works, they also found significant changes in the pressure pain threshold. It increased dramatically, meaning the patients were less sensitive, and the effect was much greater in the dry needling group than in the sham needling group. Looking at range of motion, they also showed a significant main effect of time, favoring the dry needling group. After only the second treatment, range of motion in the dry needling was already significantly higher than in the sham dry needling group. So it's kind of interesting that you see two almost identical papers, probably done at the same time, published in the exact same month in two different journals, and one showed great effects and the other did not. A lot of that has to do probably with how the study was conducted, how it was presented, the experience levels of the clinicians, and most studies do not state any of that. There are many different ideas on how to do dry needling. At Myopain seminars, we have our own thoughts. People in other course programs do different things, and we sometimes say like, wow, why would you do it that way? In other cases, I look at that and it's like, oh, that's a really clever idea. We're going to copy that as well. That makes sense. Fortunately, with some of our other dry needling providers, of course, providers, we have great relationships. We can chat with them. Actually, I had a discussion with another dry needling provider yesterday, talking about what we do in certain cases, and very collegial. In others, that's not quite as collegial. But these differences happens, and that's what science does to you. So that basically means we need to continue working on coming up with better research models. A new study, not yet in press. So I can't say hot off the press because it's not in the press yet. It's online, so you can find it if you have access to that in the Brazilian Journal of Physical Therapy. Looking at the effect of needling the oblique capita's inferior muscle and sensory motor control and cervical mobility. They claimed there was a double-blind randomized sham-controlled study. I just told you that's almost impossible. And so that's, you always have to, when I see that in the title, like, is that really double-blind? Are you sure? So what they did, had 40 subjects. They received dry needling or they received sham dry needling with a blunted needle. Yeah, some of the authors are actually Belgium in this paper as well. So they used a lot of outcome measures, cervical joint position errors, movement sense, standing balance, ocular motor control, and range of motion, flexion rotations, and pain. So what they found was an immediate decrease of the joint position errors. So people became more accurate. They didn't find much impact on cervical movement sense or standing balance, an immediate increase in active cervical range of motion, improved flexion rotation, and decrease in pain. So that was actually quite positive. In these studies, of course, more and more people are looking at minimal detectable change, which is important, and also but it's clinically relevant is another factor to do. So this was a lovely paper that actually says like, well, that worked really well. For the same muscle, another paper that also has not been published yet looked at, does it make any difference in what the experience level is of the clinician? So they wanted to look at how much experience do you have in safely placing the needle towards the C2 laminar arch using either cranial medial technique or caudal medial technique, and in uninvolved cadavers. Now, there are several papers now in the literature that promote or study needling techniques for the oblique capsule inferior that are different than we teach at Myopain seminars. And this is one of them. We tend to needle this muscle in a cranial medial approach, but we don't aim to needle to hit the C2 laminar arch. And to me, that's also doesn't make a lot of sense based on anatomy. What they did, they used 3 physical therapists. They used 50 millimeter needles towards the C2 laminar arch. They recorded an ultrasound, and then they evaluated the ultrasound videos. What they found was quite intriguing, and again makes me quite wary about some other needling techniques. What they found that inexperienced and new needlers, new clinicians were not very good at this. Yeah, some of them were fairly accurate, especially for caudal medial trial, so hitting that lamina. But in the cranial medial direction, only the experts had somewhat success with 67% accuracy, but every single clinician hit the spinal cord at least once in uninvolved cadavers. And looking at the technique, it really makes me wonder, why would you do it that way if there's a safer way to do this? But the way that we teach it, in all fairness, has not been studied in this kind of fashion. So I have to be careful with making statements that I can't support with scientific research either. We have looked at this in our dissection studies. I have looked at this with ultrasound as well, but I have not done this in a formal scientific format. So I think the time has come to set this up, and I'll see what we can do to make this happening at some point in the next 2 years or so. So the expert clinician was 10 times more likely to accurately reach the C2 laminar arch compared to the other two, and had fewer spinal cord strikes, also the cranial medial and the caudal medial technique. So the cranial medial was actually a little bit safer in that sense, but as I said, I'm not convinced that this is really the best way to needle that muscle. The upper trapezius is a very positive muscle to study because it's very accessible. And you see many, many studies in this muscle. And here's another one from Iran, where 30 students were assigned to 2 treatment groups, dry needling and stretching only, 5 sessions over 3 weeks. And not surprising, the dry needling group did significantly better than the stretch only group. So I don't think that comes as a surprise. Dry needling, much larger group for tension time headaches, 168 subjects with 160 completing the studies. Also treated for with dry needling or sham dry needling. And sham dry needling can take many different forms. Sometimes it means superficial needling. Sometimes it actually means using a so-called von Streitberger needle, where the needle is placed on the skin. When you tap it, it actually touches the skin and then goes back up in the handle. Patients have a hard time distinguishing those two, so that may work. So 3 times a week for 2 weeks, so a little bit better than just one needle stick. And with this study in 160 chronic tension time headache patients, they were able to show that it was safe, it was effective in reducing headache intensity, frequency, duration and improving the quality of life. When you have less headaches, you automatically feel better. There's no question about that. One study that addressed an issue that really has not been studied much was on effect of dry needling on respiration. With COPD, there's something missing from the title, but that was in the paper itself. So, with COPD, so they used dry needling. They did see, there's a case report, they did see improved function, but because it was a case report, they couldn't really say whether the dry needling made all the difference. But that was the only thing that they looked at specifically, but they did other things as well. So another case report published in Rehabilitation Oncology looked at a woman with breast cancer. 46-year-old lady had bilateral mastectomy, implant surgery 6 years earlier. We know from other studies, and one was published in the Journal of the American Medical Association, that up to 50% of patients with mastectomies have severe pain. And most oncologists don't really know how to address that. So this is a very interesting study and for a very common problem. So this patient developed severe lymphedema, contractions around the implant, pain levels reported 6 to 8 on the 10 scale. She had several PT efforts to resolve this, but never resolved what she's called chest wall tightness. So the pain increased after PT, and then she had dry needling. So she had 3 sessions of dry needling, about 3 weeks apart. They around the breast capsule, near the drain scar, near the pectoralis minor. They're very careful to make sure that they knew where the implants were. They used 30 millimeter needles. The needles were left in place in some locations, and some of them they used e-stem as well for about 5 minutes. They saw a 70% improvement in the symptoms for all but one location, and which was 50% better. And they did a second series of treatment, and this patient had a 90% resolution of the pain in the chest. So this is very important, of course, for a very common problem. Needling near implants is a bit risky, potentially, although I don't mind sharing with you that although we still recommend to be very cautious, in our last dissection course, we actually needled an implant, and much to our surprise, it was not that easy, actually impossible, to create a puncture hole in the implant to create leakage. Having said that, that does not mean that we should be less cautious in needling near implants. This is one implant that had been in a closet for quite a while. I have no idea if all the implants are the same, if the material is the same, if it's different in different individuals. We have no idea. So our precautions stay the same. We do recommend to be very careful and possibly avoid needling near implants as much as possible. Okay, let's go back to a few more clinical papers. Here you see a paper I had the pleasure in participating with Pasha Mubimadi, official name Mohammad Reza. This was a review article, but very extensive review article that we actually got accepted in the Journal of Anatomy, which was quite surprising. We did not really have high hopes that it would get accepted because it has a fairly low acceptance rate. But it was quite interesting, and actually we got an award from the journal because it was one of the most downloaded papers apparently. So it helped with their impact factor, I'm sure. So they were very happy. So basically, to summarize the paper, what we found is that atrophy of hip muscles is very common in patients with low back pain, and based on the review of a lot of literature. So the conclusion of that paper, and I don't really do it justice, but is that if you have patient with back pain, to also consider hip function, hip muscle function, through exercise programs and potentially also by doing other things like I outlined before in patients with low back pain. So that was basically the conclusion. So since then, there are actually several papers that looked at is there indeed a benefit to adding dry needling to exercise programs in the gluteal muscles, for example. So again, same thing, one session of dry needling or sham dry needling. That makes me worried already. Added to a 4-week exercise program. 46 patients with chronic low back pain, so the needling, and they used the sham needle, the Park Sham device. That's just a similar needle where the needle goes back into the handle. They used a few outcome studies, the Walnut Morris fear avoidance beliefs questionnaire that looks at kinesiophobia, pain pressure thresholds, and pain itself. And what they found, even with only one session of needling, that both groups showed significant improvement. So exercise itself did fine, even with the sham needling. But the dry needling group did significantly better at the 3 months follow-up than the sham dry needling group. For the pressure pain threshold, that was the same as for all. And they concluded that adding dry needling is useful. Again, I have issues whether you can really conclude that from this study based on one needling session in one muscle once at a time. So I'm honestly not convinced that papers like this make a lot of sense. They help, they contribute, but I would not draw a lot of conclusions based on this paper. How about dry needling of the piriformis? So in this study, where they had ultrasound guided dry needling or wait list, control group, look at pain intensity, visual analog scale at different intervals up to 1 week. They found that needling the piriformis muscle was definitely significantly better for pain than the control group, by found consistent clinically meaningful improvement. You can see here the different outcome studies in the diagram, and it clearly favored dry needling in pretty much every outcome measure. So that's interesting. Then the question is, how safe is it to needle the piriformis? Isn't there a sciatic nerve underneath that? Well, in 93% of subjects, based on a fairly recent anatomy study, the sciatic nerve was deep underneath the piriformis. So that's one thing. So here's an older paper from 2018. This is in Journal of Manual Manipulative Therapy, where they looked at, can you safely place that needle in the medial 1/3 of the piriformis right as it exits from the pelvis. This is in uninvolved cadavers. Can you avoid needling the sciatic nerve? And if so, can you come up with some guidelines for needle length? They use 19 different cadavers of hips of cadavers. The needle reached the medial half of the third of the piriformis in 16 out of 19 hips. They found there was fair and good correlation between the needle length and the mean fat thickness for the right and left hips, respectively. And I was very kind to see this. They actually used our dry needling technique that we published in our textbook. They said it was 84% accurate in reaching the medial piriformis muscle in these 19 cadavers. They also felt it was 100% safe, as it never touched the sciatic nerve, and they used 75 and 100 millimeter needles for a main estimated body mass index of 27.3. So it's nice to see that some people actually challenge us and look at what we publish in our textbook and see, does that actually make sense? And our 84% is pretty good. 100% safety is, of course, excellent. Looking at another study of needling hip muscles, in this case with hip osteoarthritis. I already mentioned to you there's an older paper from the 90s from Brugge, from Denmark that showed it was very, very useful to do that, to decrease the symptoms of hip osteoarthritis. This was 30 patients. They had a dry needling group, a sham dry needling group, 3 sessions in different muscles, as you can see here, glute medius, iliopsoas, rectus femoris, and the TFL. They looked at pain, hip range of motion, and physical function, and all improved in the dry needling group. So that was very positive, and certainly in the clinic we see the kind of the same thing. Another study that was also published last year. Does it make sense to add dry needling for knee osteoarthritis? Does it make sense on pain and disability? It's 62 older adults, evenly divided between the 2 groups. Lots of outcome measures as well, and arthritis index, a self-report questionnaire, timed up and go test, some functional testing. They did 6 sessions of dry needling. Some of the same muscles, also hamstrings, quads, gastroc, popliteus. Again, this is for knee osteoarthritis. And interesting, they found no differences between the 2 groups. Side effects, they were very okay. They really not much going on, and then post-needling soreness and some hematoma. But they did not see any differences between the needling and sham needling group, so that was kind of disappointing compared to the other study. The popliteus needling, is that safe? Well, there's a cadaver study on that, as well. In cadavers using a 5 centimeter needle, published this year, so very recent. So they looked at 11 cadavers. Can you place that needle accurately into that muscle? It was quite good. Actually, the accuracy was 91% in 10 out of 11 cadavers. It was done perfectly fine. And the distance to the tibial nerve and the popliteus fascicular bundle was over 1.5 centimeters. So that was very excellent as well. So that there's actually an ultrasound guided method to do this as well on live patients. And that actually also shows that you really don't have to worry about it as long as you stay relatively close to the bone, to the osseous structures, to the bone itself. Effectiveness of dry needling on exercise in cervical myofascial pain. Now, how they determined that the dizziness was due to trigger points, I am not really sure. The paper did not explain that. They did have a statement that I literally quoted from the paper that it's seen in 35% of patients. It did not have a reference either, so I don't really know what that was based on. But nevertheless, they did exercise for dry needling versus exercise. The familiar outcome studies, pain, algometry, fall index, and a dizziness handicapped inventory with a 4-month follow-up. So follow-up was very impressive. What they did, they needled the SCM, the upper trap, twice weekly for 4 weeks. So that's a much better concept than needling someone once. They did turn the needle in the trigger point and left the needle in place for 20 minutes. There are schools who believe that that is more effective. That really hasn't been studied that much either. What they found that both groups were effective, but there was greater improvement in the dry needling and exercise group for severity of neck pain, thresholds, dizziness attacks, severity of dizziness, and the dizziness handicap inventory, but not in the fall index scores. So overall speaking, dry needling and exercise was much more effective than the exercise alone. So one study, something that's not really done in the US, but certainly done in Spain and Mexico and South America, Central and South America, is a technique called electrolysis. And electrolysis is not in the States, that means a technique for hair loss. not a dry needling technique, but electrolysis in this percutaneous electrolysis means usually ultrasound guided dry needling approach, where a needle is placed directly into a tendon, in this case the supraspinatus tendon, and a galvanic current is delivered through the needle directly into the tendon. This was promoted several years ago. For many years it went without any research, and it's now interesting to see that there are actually a few studies coming out with about percutaneous electrolysis. When I first got introduced to this with Acupuncture, the APS needle manufacturer, when we talked about does it make sense to have this unit that can do percutaneous electrolysis available in the States, I actually suggested to change the name, but that doesn't seem to make sense either, because then you study different things the same thing with different names. So it probably should stay the same if people plan to do that in the US. So what they found, 36 subjects, but a 1-year follow-up, significantly, so they compared percutaneous electrolysis with regular dry needling, and they found that a year later, the percutaneous group did actually much better in pain, range of motion, and pressure thresholds. Now, I do not recall how the dry needling was done, but it is an interesting concept to see that a different approach to treating tendinopathies. And this has been used on patellar tendinopathy, supraspinatus, Achilles tendon, and others. But it is all fairly new, and certainly for the US participants in this webinar, probably something that's rather unknown to you. Okay, let's go on. Another neck pain study. I told you the trapezius is a popular muscle to needle. 101 participants with a control group. 2 treatment sessions, not great, better than 1, but still not great. Same outcome measures you've seen before. Showed again the dry needling. You see it here in the graph already. Dry needling compared to sham dry needling was effective, significantly better than the sham dry needling in improving all these outcome measures. You see here the graph for the pressure pain threshold and for the neck disability index. In every single measurement, it was preferred over the other one. Here's another study about E-stim. 2 groups of shoulder pain with adhesive capsulitis. That's another questionable diagnosis in my mind. Do these people really have an adhesive capsulitis, or do they have an inability to contract their muscles in the most efficient manner? And there are studies that show that people with shoulder issues that can't lift up the arm may fire the muscles in an abnormal pattern, and that may be more common than adhesive capsulitis, but that's an opinion. So here they used therapeutic exercise. 1 group got electrotherapy, intramuscular dry needling, and the other one just dry needling. And they looked at 5 days a week, doing 2nd and 3rd week, they had exercise. Again, lots of outcome measures, kinesiophobia, number of trigger point, range of motion. With a 3-month follow-up, I love that. It's always great to see that. And what you see here, that indeed both groups did better. But what they actually found was that the intramuscular E-stim group had greater improvement than the just dry needling group in some of the parameters, but it was not always clinically relevant, especially for pain and the DASH outcome. So again, there's papers than this are coming out more and more. This paper has not been published yet either, or maybe it just got published. But it's kind of in favor of you adding E-stim to your dry needling. This paper is not published. I looked at the next slide already when I said that. Effect of dry needling on mechanical and contractile properties of the upper trapezius again. This is still in press, so not yet in paper in the print, the Musculoskeletal Science and Practice Journal. They looked at dry needling and found indeed that dry needling decreased stiffness, decreased muscle tone, decreased contraction, and decreased pressure threshold, which was unusual, but it was only measured within the first 72 hours, so patients probably still had post-needling soreness. Increased radial displacement, that's just a measure of can you move the tissue, the muscle, the upper trapezius a little bit better, and that was actually better after dry needling. All right, hope you're still with me. Have a little bit more to go. Let's take a quick look at some other studies that don't really look at trigger points, but did include dry needling. So I'm part of a research group in Iran, and Dr. Ansari is usually the leading force in these studies. And this was a study, can you use dry needling to help patients with quadriceps muscle fatigue? So this is a pilot study, as it says clearly in the title. So there's no control group. That's the next phase if this shows to be productive. So 15 college students at one session of dry needling for 3 minutes only. So really just a pilot study in the vastus medialis, lateralis, and rectus femoris. We did some functional testing with them, single leg hop test, for example, isometric peak torque. Before and after we made them fatigue. So they got tired, they got dry needling, and then we said, okay, does the dry needling leads to recovery quicker than if you don't do dry needling? So what we found in this study, that in this very small pilot study, dry needling had a significant effect on the recovery of quadriceps muscle fatigue, functional performance, and balance. This picture shows you where the needling was done. So this was not done in trigger points. It could have been a trigger point there, but that would be pretty coincidental. It was on a fairly arbitrary choice, somewhere midway the muscle, the three different muscles between the ASAS and the patella. It looked promising. So the next phase of this research is to do a larger study with a control group, et cetera, to see if this really pans out. Very similar, we did something like this for the hamstrings. And in this case, we didn't look at fatigue. We looked at hamstrings flexibility. This was also a pilot study. And same thing, this mid-muscle, just a fairly random point was needled, and showed a significant improvement in hamstrings flexibility without actually doing any stretching. Just the needling itself increased the patient's flexibility. Now, this paper was terribly delayed in getting published. It was published in Journal of Sports Rehabilitation last year. You see at the bottom of your screen, it was in issue 29. And when this was done, we immediately went on to a controlled trial doing the same thing, basically. And funny enough, it was published in the very next issue of the same journal. So it's kind of funny. They're really hard to keep track of each other because they're almost the same. But here we had 50 healthy subjects, and we compared dry needling with static stretching. And again, the dry needling group did better than just the stretching group. Both of them got better, but the dry needling group beat the actual stretching group. So the next step in this research would be to look at people who don't get anything, no stretching, no dry needling, but that was not in this format quite yet. So who knows where this goes? We don't know. This is all like thinking out loud together via email. Like, what about if we do this? What about if we do this? So that's where we ended up. I'll show you one more of those as well. Let's take really a quick look at fascial needling. And chapter 3 of the new Travell and Simons book, I mentioned to the editor, Joe Donnelly, that it's kind of weird when he took over the editing of this new book. So it's kind of strange that Travell never mentioned fascia in the previous editions of this book. So next I knew I was charged with, why didn't you write a chapter on that? So here it is. And it is, I think, very important. I think fascia will take a much greater role in the future in our dry needling practice, but also in our clinical practice, looking at myofascial pain. There are not many papers yet, so it's all a little bit theoretical still at this point. Here you see one paper from Canada, where you saw the effect of fascial needling on non-specific thoracic pain. The needles were placed in the thoracic spine from T2 to T7. Discharged after 4 treatments, and at follow-up 3 months, he was totally pain-free and quite happy. So this is only one example, just a case report. Another case report that some of you have taken the dry needling courses very recently may have seen this already. I've added it to one or two courses. Also a case report, patient with shoulder pain, right shoulder pain, significant range of motion limits. And they did ultrasound. They found this very thick fascial layer between the deltoid and supraspinatus muscle. They decided to needle directly with ultrasound guidance directly into that fascial band and saw a dramatic improvement in range of motion and in pain report just by needling the fascia. Of course, they went through the deltoid muscle to get there, but the target was really needling that fascial band. I have done something similar in my clinic. I did not write a case report about it. We probably could still do that actually, because we do have some data for that. This was in a patient with Peyronie's disease, and so traumatic injury to his penis, and usually ended up in a very crooked shaped penis. We had treated him a few times, and then actually we looked at ultrasound in his lower abdomen, right at the base of the penis, and we found a similar fascial band, which we then needled also under ultrasound guidance. And in one treatment, this man was so happy because it had been 5 years that he'd been suffering with this, and one treatment into this fascial band in his lower abdomen corrected this problem to a significant effect. It's a significant deal. So this is something, if you have ultrasound available, and ultrasound is becoming more and more affordable, it is something I think that many of us will do more and more in the future. Okay, let's look at a few comparative studies, dry needling versus something else. Who wins the battle? Is it dry needling? Is it something else? It goes both ways. Here's dry needling versus pressure release over the scalene muscles, looking at pain, disability, and respiratory capacity. Single blind trial, so a single session, not great. 30 patients, active trigger points in the scalene muscles, 15 in each group. Dry needling had a greater decrease in pain in 1 month than the pressure technique, but not right away over 1 week. But it did not reach clinical importance difference of 2.1 points. And also, if you look at the disability rating, did not reach important clinical difference either. It was better, but not better enough to be quite that significant. Limitations, of course, one needle session, one muscle. Very few people only have trigger points in one muscle. There was no placebo sham needling. It was a non-pragmatic design, small sample size, and a very short outcome period. So that's often the case. We don't know what would have happened if they had corrected all these limitations, but that's just a short list that I could come up with myself. Looking at another study of dry needling, soft tissue mobilization and dry needling, instrument-assisted soft tissue mobilization, like as you see here, 81 subjects, 4 treatments over 2 weeks, so that's a little better. Similar outcome measures as we've seen before many times with a 1-month follow-up. They saw no differences between the two groups. Both the instrument-assisted technique and the control and the dry needling were effective compared to the control group. How about dry needling versus shockwave therapy? Again, back to the upper trapezius, and again, very easy to do. Single session of dry needling or shockwave therapy. So there we go again. It gets old. They did not find any significances between the two groups. Now, shockwave therapy, if you have real shockwave therapy, this looks more like a pulsed shockwave. There are much better shockwave units on the market, but they're still $25,000 and upwards. I think that's a little bit different, but shockwave therapy can work very well. Many years ago in Munich, we actually got a demonstration of that with David Simons and Carl Levitt and several other people, and then a great clinic in Munich. And the shockwave therapy was able to elicit familiar referred pain patterns, and actually we could just on each other could see dramatic changes. But there are some studies on that, but none that have compared it. Again, with the one treatment session, what does it really mean? Dry needling versus ischemic compression. I doubt that they really got ischemic compression. You need to press really, really hard to get ischemic compression. Simons changed that term to trigger point compression in the second edition of the trigger point books from Terrell and Simons. But the term ischemic compression is so ingrained in people that it will continue to pop up forever, I'm afraid. 30 for triathletes, trigger points in the gastrocnemius muscle. Ankle dorsiflexion and plantar pressures. They did not see any significant difference either. But again, that was really with the same limitations. Another trial, non-thrust manipulation with segmental distal dry needling. Yeah. So 65 subjects over 6 sessions over 3 weeks. This time they used the oswestry, functional scale, pain rating thresholds again. And what they found that the between group effects were neither clinically or statistically different or significant. The within group effects were significant, exceed the minimum reported clinical outcome, except for the PPT, so for the thresholds. So they were very comparable. And the dry needling had slightly greater improvement, was not significant, level to a level of significance. So that means you have different options in what you want to do. That there's more to the world than just dry needling. Comparison of pressure release and phonophoresis and dry needling. And latent trigger points back in the upper trap. 60 participants, 3 different groups in each. And they found that the dry needling and phonophoresis was the most effective. Again, these comparative studies are kind of interesting, but not really all that useful. It just tells you that you have different options in being able to treat your patients. And also for patients who really don't want dry needling, there are other options you could consider. But all these studies suffer from methodological issues. Let's look briefly at some neurological dry needling studies. Yeah, that's becoming more and more popular. Dry needling, in this case, a paper called Dry Needling Decreases Spasticity. So it already gave the answer in a spinal cord injury, incomplete spinal cord injury. And they found that dry needling had significant positive effects. And you see the table here on spasticity, dynamic stability, self-independence, pain, and that particular patient group. Myofascial component of pain in a painful shoulder of a hemiplegic patient. In this case, they used trigger point injection, so not dry needling, and trying to decrease spasticity, but mostly trying to decrease pain in spastic muscles. And what they found, it actually reduced pain as much as 50% of the stroke patients in 4 months. So it's quite dramatic. You see here the graph. So trigger point injections were actually able to help that a lot. Study both post-needling soreness. Is it any different for patients with a hemiplegic shoulder following stroke? So they wanted to investigate that. 16 patients are fairly small. Same dilemma, single session of dry needling, and including the regular stroke rehab program. It was better. You can see here 50% of these patients had post-needling induced pain, but it disappeared within 72 hours. And again, what I said before, do we really have to worry about that too much? You saw that here. The top graph is the post-needling soreness. The other one did reduce their shoulder pain. That was also quite effective. Even that one session did reduce their shoulder pain significantly. If patients can come in and you can teach often family members to do manual techniques, we've already seen several papers that show that that can work quite well as well. Does it actually change muscle tone? function in these patients. This is the same research group, just a different first author. So they wanted to see if dry needling does any of these things at 6 weeks. The patient treated twice, 2 sessions total with 6 weeks in between. I'm not sure why they picked that format. That seems a bit arbitrary. They looked at lots of outcome studies, including the modified Ashworth scale, and set up other functional ratings up to 6 weeks by a blinded assessor. And what they found, there were actually changes in muscle tone, but they were similar in both groups. But the decrease in shoulder pain was higher in the dry needling group. The problem with needling stroke patients is that can the dry needling actually change anything in the central lesion in the brain? That is a question that really has not been answered. Or do you need to continue the dry needling to give those patients continued benefit from the needling? Here you see some of the outcomes, and you see that it worked really quite well. And it didn't really matter, and that's important also, whether they needed inside at a trigger point or just in the muscle itself. We've called it in our textbook a global twitch response, that you can kind of just don't really have to look at trigger point so much. This needle where the muscle is the tightest needle there, you will get a global twitch response. That's a term we just made up. I've used the same muscle, but also the antagonistic muscles may contract very, very quickly. In this paper, they found that these effects were maintained to 6 weeks after treatment, which is very encouraging. Another case report of dry needling in a patient with the lower limb spasticity with a brain tumor, an epidemoma, a brain tumor or spinal cord tumor, in this case a brain tumor. They needled the gastrocnemius in the lower extremity, and also the upper limb spasticity. They needled the dorsum of the hand between the first and second metacarpal bones. I mean, it's kind of that spot right here, used in stroke rehab as well, trying to manually release patients' hand of spasticity, and also in the flexocarpia radialis and ulnaris. And what they found, that indeed that was quite effective in improving the performance and decreasing the spasticity in hemiplegia due to a brain tumor. Along those lines, a case report that I participated in Iran used that same point. You see that here in the diagram, in a patient with a stroke following, a stroke with spasticity in the hand. We needled that spot, then the spot was needled once. But in this case, we thought it would be interesting to take a look at what happens in the brain itself when you needle that one spot once. So we looked at hemodynamic changes using what's called a Bolt technique, Bolt imaging, which really looks at blood oxygen levels. Unfortunately, this paper was published as a letter to the editor, which means that the pictures of the functional MRI could not be included in the paper, but the first author of the paper had to graduate, and her graduation depended on getting a paper published. So we all agreed this was just a case report. It was not a big deal. So we did submit it. It was accepted in acupuncture and medicine, but it was really a descriptive paper without any of the illustrations. So what we found is that this one individual had a significant activation of the motor cortex of the brain on MRI, but it also improved the wrist flexor spasticity and hand function. But when we looked at the brain more specifically, here you do see these pictures that were not published in the paper. After dry needling, there were significant areas in the brain with multiple areas with significant increased blood flow. And the fact that multiple parts in the motor cortex, the somatosensory cortex. So this is really quite encouraging. This is the first time that I know of that, other than the basic study I showed you at the very beginning of this webinar, that there is actually some proof that dry needling may change blood flow in the brain, which of course could be really good news for people with strokes and neurological lesions in the brain. Right before COVID, when this was finished, we initiated doing this as a formal study in a much larger patient group in Iran. It's done in Tehran as well. Different research, the same research group as before. I do not actually know what the status of that research is now. I'm sure that the COVID did not help very much with that. There are multiple other papers in the literature that look at this, too much to cover here. But there are many, many more will come out. There's several research groups in the world looking at spasticity and dry needling. And I'm very encouraged by that one case report that I just showed you. That could be quite interesting. Up to the last part of this webinar, we'll kind of almost just make it in the time we have. We're going to look at systematic reviews and meta-analysis. Now, you've seen these illustrations multiple times, and systematic reviews and meta-analysis are really placed on the top of this pyramid, because rather than look at one study, which we've done now, if you can look at a whole bunch of studies that looked at the same thing, then you can say, okay, one study shows dry needling worked, another study showed it didn't work. What if we look at a whole lot of studies and do a systematic review to limit the bias of all these individual researchers, systematically assemble papers, clinically appraise them with a protocol-driven method. So systematic reviews use protocols in how you should be doing this. There are lots of tools on the market, and so that's really good. So you see that here, just to refresh your memory of the systematic reviewers. A meta-analysis is usually part of a systematic review. Not everyone does that, but that uses statistical techniques to kind of look at the results of all the studies you include in the systematic review so that you can actually say, well, does it make any sense? You can consider the potential biases, but then you can say like, hey, we can look at a much bigger picture that individual studies by nature cannot look at, and therefore you improve the accuracy of the assessment. Two other terms I want to introduce you if you're not familiar with them, the between group mean differences. So that measures the absolute difference between two values. In clinical trials, gives you kind of an idea like how much does it differ from the average of the experimental group and the control group. And there's also another term that's important, the standardized mean difference. And you'll see these terms pop up in the next few patients. So that's a way to measure the effect size, so that different study results can be compared. So a standardized mean difference of 0.60 in one study is the same as a standardized mean difference in another study of 0.60. So you'll be able to compare those studies in a slightly better way, which individual studies by nature, of course, can do. So here are a few systematic reviews and meta-analysis. These are all from the last 2 years. And there's actually a blog on our website where many of these studies are reviewed. And you'll see that many of these papers show significant support for dry needling. And I tie that into then why do insurance companies still refuse to pay for dry needling? If the highest level of evidence, the systematic review of meta-analysis, shows significant support, what are you waiting for? You can save a lot of money by improving dry needling and actually pay us for what we do. This study looked at knee osteoarthritis, and we already did one study that said that didn't really make any difference. Out of 247 studies that were considered, 9 were included, and because of strict criteria. And they did find significant differences, mean difference for pain and function post-treatment. There was significant difference for using e-stim, but there were not enough studies just on trigger point dry needling itself. So that's another problem. If there's not enough studies, you can't do a systematic review. Here you see one on superficial versus deep dry needling. This is in 2019 by Griswold. This was also Journal of Manual Manipulative Therapy. 12 studies were included. 10 were eventually done for systematic review and meta-analysis. Clearly supported deep dry needling over superficial needling. But again, that standardized mean difference of 0.585. So now that's compared to other papers that have looked at that, and a non-significant effect for disability. This one also showed that the deep over superficial needling, as I said, was level 1 levels, but the difference between level 1A level, the difference between the groups was not necessarily clinically meaningful. That doesn't mean it doesn't work. It's just that the studies that have been published often have low to moderate or very low sometimes evidence. That just means that there are not enough studies that have done with enough good methodologies to support all this. But almost all the systematic reviews are positive. In this case, 9 studies were included. They showed low to moderate evidence, and many times it's low evidence because studies are not blinded. And using blinding, and as I said before, is very, very difficult. That immediately will knock down the level of evidence from a particular study. So they looked at a combination of dry needling with other interventions. There was evidence to improve pain intensity, pain-related disability, pressure pain threshold, cervical range of motion, and neck pain. Again, that an insurance company should look at that and say, hey, we should probably pay for this because it is effective and it will save us money. And there were only short-term effects that were found. It doesn't mean there are no long-term effects. It just means that the research that stands right now did not really show that. And that's, of course, when the insurance company kicks back in and says, oh, there was no long-term effects. Why would we bother? Effective management of stroke, we looked at a few patients. Significantly large effect size for reducing spasticity, post-stroke pain, and pressure pain sensitivity. Here's one on management of knee pain. Low to moderate evidence in pain-related disability, but not for knee osteoarthritis. We saw that in the other study as well, and not for post-surgical pain. And mostly benefit was in the short term. These systematic reviews almost always also look for bias in the studies, like how much bias is in the individual studies, and that's usually portrayed as you see here. Most of these studies had a very low risk of bias. Systematic review, meta-analysis on fibromyalgia and dry needling and acupuncture as well. They looked at both, produced a significant reduction in pain, impact of fibromyalgia, pain thresholds, and improved the quality of life. So again, looking at these meta-analysis, they are quite positive about what you do in your clinic with dry needling. 6 studies in this review looking at dry needling and manual trigger point therapy with neck and upper back pain. Again, significant for pain and function, but in the short to medium range. Another one in looking at shoulder pain, or neck pain, sorry, neck pain, shoulder pain, moderate to low effectiveness, small effects out for pain with large effects out for disability. Is it effective for pain in musculoskeletal conditions? A very broad research study. That's why they found 1,771 papers, because the study was set up so broadly. They included 42 papers. That is a lot of work to analyze that many papers. The systematic reviews take a lot of effort. Low quality evidence, they found immediately 72-hour large effect for in the longer term, and moderate quality evidence 1 to 3 weeks found moderate effect. And it all depends on how the research was done. Dry needling by physical therapists in that study was more effective than no treatment, more effective than sham dry needling or other therapies for reducing pain. Right away, in the long term, up to 24 weeks, 72 hours, 1 to 3 weeks, it all was skewed towards dry needling being more effective than any of the other procedures or sham dry needling. Here you see it in the 4 to 12 weeks. So a paper you can find in physical therapy, but it has not been published. It's only on the website. There's a paper that I actually participated in, a systematic review in dry needling of headaches, tension type cervicogenic and migraine headaches. It truly takes a village. I want to show that how many people were involved in this study. It was a lot of work, but Mohammed Reza Poramadi, you saw that name before. I figured I'd put a picture of him in there. He's really the brain behind these studies. He does lots of these papers, and I've had the pleasure of collaborating with him on multiple papers. This study started over 2,700 papers. 11 studies met our criteria for quantitative synthesis or systematic review, and 9 for the meta-analysis. Of all those papers, only 4 were considered high quality, which is, of course, a problem. Very low quality evidence showed that dry needling is not statistically better than other interventions for improving headache pain intensity in the short run, and that's for tension type headaches, cervicogenic headache, and mixed headaches. But it was definitely, based on our analysis, effective for reducing disability, in particularly tension type headaches and cervicogenic headaches. So we still concluded, based on this very large study, that, again, a lot of work, that dry needling could significantly improve headache frequency, quality of life, trigger point tenderness, and range of motion. We were very happy to see this approved in physical therapy. This is not an easy journal to get published in. They're very strict and on their criteria. So you can find this online. It will appear in the journal at some point in the near future, hopefully. I checked the wait list. There's still lots of papers ahead of this one before it gets in print. So it is all there. Neck pain, associated with trigger point, dry needling versus trigger point injections, a systematic review. 7 studies were included. Trigger point injections reduced pain intensity with large effect size. They did not see any differences between the two, between pain-related disability, pressure thresholds, flexion, and depression. And I want to make a comment on that, because most of the studies that were part of this study that they included in the systematic review suffered from the same problem I've said many times now: 1 needle stick versus 1 dry needling. Dry needling, in my opinion, is still more effective, even though this systematic review does not show that, because in dry needling you can do a lot more than with injections. Injections are slow. You need to prepare the syringe, you need to prepare the bottles, you need to draw the solutions. It is time consuming, and you can only do so much. With dry needling, in a pragmatic clinical approach, you can do a lot more. In my own clinical experience, dry needling is much more effective because you can address so many more things in the same session, same timeline. How about plantar fasciitis? 6 studies were included, moderate to low quality. Positive effects for pain, disability, and plantar heel pain. Yeah, you see that here again. The short, mid, and long term, so that was very nice to see as well. How about pain? Electrical stimulation on pain and tenderness. It was only a systematic review. 15 studies, small sample sizes. Electrical stim was effective overall. Didn't matter if it was high or low frequency. And they also found that sessions of more than 15 minutes were more effective than shorter sessions. And they looked at TENS and electroacupuncture. Systematic review of dry needling, of manual therapy, cupping, and dry needling. 23 studies on dry needling, 8 on manual therapy, 2 on cupping. And what they found, that there was very decent support for manual therapy, very low to moderate support for dry needling, and there was not enough data to make any statement about a cupping itself. So I showed you this picture a long time ago when we first started, and I said, it looks like a lot of chaos, and the information comes from all kinds of information in the dry needling world. What's really fun about this particular piece of art, if you look at that building in the background, the one on the far right, you see it in the next picture as well. If you walk about, I'd say 150 degrees to your right, there's actually a little picture frame. When you look through that picture frame, this mess of nonsense actually looks quite funny and very organized. So I hope that with this, it's the exact same pile of junk, just from a different angle. It looks like a bunch of camels. So I think that was really kind of cool to see. So that brings us to almost exactly 12 o'clock. So we actually made it through this 3-hour rambling of a lot of papers. I hope I didn't bore you too much. My journey in myofascial pain and dry needling started with this remarkable lady, Janet Travell, who I met in 1989 for the first time. She was Kennedy's White House and Johnson's White House physician. And here's a quote from John Kennedy, who made this, for Dr. Travell, who made the smile possible, with affectionate regards, John Kennedy. So why do we do this? To take so many people to the middle of nowhere so it becomes somewhere. I hope that I've shown to you that, yes, we are getting somewhere now in the whole dry needling land. There's a lot of research. I could have done a lot more research. We could have done this 8 hours. because I had to make a lot of choices in what research to include and what not to include. So that pretty much brings us to the end of this webinar. And I know it was a lot of words in a very short time. Appreciate it very much. And we hope to see you at a future Myopain seminars activity. Bye-bye.